Good morning. This is Dr. McDaniel at GYN Corner. I'm a board-certified obstetrician gynecologist in New York City, and I'm bringing to you all things health-related for women. Thank you for joining me today at GYN Corner. And let's see, as the title stated, I'm speaking about ovarian cyst again. The last presentation I spoke about ovarian cysts that we call hormonal or functional cyst, and today I'm speaking about dermoid cyst. Now we call them dermoid cyst. They're also called mature cystic teratomas, and teratoma comes from the Greek word teras, which refers to monster, and that's because they look pretty grody, pretty monsterish when you look at these cysts, as opposed to the functional cysts, which are either clear water fluid filled cyst, the follicular cyst, or the corpus luteal cyst, which is filled with blood. Dermoid or mature cystic teratoma is filled with particles, material, substances that come from our skin layer. That's called the ectoderm. So when we are all developing as embryos, we have three what we call germ layers, or three layers that eventually produce all of the cells in our body. Those cell layers are called ectoderm, which is from ecto, which is the outside, the mesoderm, which is the inner lining or the inner tissue developments, and then the endoderm, which is predominantly the organs and the deep inner tissue manifestations of our body. The ectoderm is skin, hair, nails. It also includes the eyes, bones, cartilage, so all of the outer surface area of our skin, of our bodies. So dermoids or mature cystic teratomas, they involve tissue development that forms inside a ball of liquid that represent all of the skin type of manifestations or body parts. So these cysts, and from the last presentation, I made the statement that a cyst is a pocket of fluid or liquid. So these dermoid cysts are pockets or balls of liquid that contain usually hair, fat cells, sweat glands, oil, sometimes teeth, cartilage, small bones, and occasionally eyeball materials. Sorry, I have allergies, so I'm coughing a lot this week. So dermoids or mature cystic teratomas, 98% of the time are benign. Less than 2% of dermoids will have material that's from the skin or ectoderm that starts to transform or change into cancer, such as, even though it's rare, less than 2%, melanoma. Even though it's not exposed to the sun, it's in the body. Melanoma, malignant melanoma, is a rather fairly common one. Now, when someone has a dermoid, the predominant age group is going to be in the 20s to 30-year-old age group. So 98% are benign. The majority of dermoids will be seen in young reproductive age women. Dermoids can also be seen in younger women, in girls and teenagers, and dermoids represent over 90% of what we call neoplasms or abnormal growths in young girls and teenagers. Dermoids for the 20 to 30-year-old or overs represents about 15% of all neoplasms or abnormal growths. Now, when someone has a dermoid, they usually do not have any symptoms. It's found incidentally. She comes in for an exam, for an annual exam. We do the pelvic portion of the exam. We feel a mass. Or very rarely, occasionally, if they get quite large, she'll have pressure discomfort with sexual activity or with exercise. sit-ups, running, jumping, that kind of activity will feel a pressure or discomfort. Won't manifest as sharp pain or cramping, won't manifest as any kind of hormonal problems or abnormal bleeding. It'll usually be picked up incidentally, just because we're doing an exam or because she's getting an imaging study for another problem, and then occasionally with exercise or sexual activity, discomfort or pressure will be noted. Most dermoids will not be picked up until they're usually around 5 to 6 centimeters. That's usually when we can note on a pelvic exam that the ovary is enlarged, because the normal ovarian size is 3 to 4 centimeters. Top normal ovarian size is 5 centimeters. So if we as gynecologists are doing a pelvic exam, we're not going to really note that the ovary is abnormal or unusual unless it's over 5 centimeters. So since the majority of dermoids are benign, we don't recommend intervention unless it gets to be over 5 centimeters. And that's because the ovary, if it's filled with a mass, so fluid, oil, hair, cartilage, all of these different materials, it becomes a lopsided or an uneven ball of gunk, and the ovary is held up on one end by the firm tissue to the uterus, that's the suspensory ligament, but the other end to it that it's held up on is blood vessels. So it's a vascular pedicle with the artery and the vein that's giving it blood and receiving the venous blood. If it gets heavy and lopsided full of this gunk, it can start to twist on that suspensory pedicle, that's blood vessels, and it will cut off or choke off the blood supply. When it does that kind of twisting material, because it's uneven and it torques, that can cut off the blood supply. We call that a torsion, and that's a medical emergency because, one, it causes extreme pain when you lose the blood supply to that ovary. It's exquisitely painful. And two, you can lose the ovary that way. You cut off the blood supply, the ovary dies, it necroses, and you're going to lose that whole ovary. So over 5 centimeters has been documented as increasing the risk of torsion, and the larger the ovary gets, the higher the risk of torsion. Now, dermoids can become quite large. Obviously, all cysts start off as minuscule in the ovary. They all start off inside the ovarian tissue. As they get larger, for dermoids, we just monitor them because they grow quite slowly. So statistically, the dermoids have been rated as growing about 18 millimeters per year. And 18 millimeters is about a staple length and a half. So it's very slow. So they're very slow growing, and we monitor them slowly over time. Some of them will grow even slower than that. And then if they get to be around 5 centimeters, then intervention is needed. The only way we monitor dermoids is with an ultrasound or a sonogram. And that will give us all of the characteristic features to confirm that it looks like it's a dermoid or a mature cystic teratoma. We'll see evidence that looks like there's predominantly oil and hair is usually what's found, or gunky material. And as long as the features look benign, so it should have a smooth wall or a smooth capsule as it grows outside of the ovary. The ovarian tissue forms a capsule or a lining over that dermoid, and it should have very minimal blood flow. Abnormal or increased blood flow often increase an abnormal or increased growth or rate of abnormal tissue change, because abnormal growth garners abnormal blood supply, and that could be precancerous or cancerous malignant change. So it should have a low blood supply and a smooth walled capsule. And then it should look like it's just filled mostly with hair and oil and gunk and debris is what we call that. So if it looks benign, we monitor it, and if it's benign, it should grow very, very slowly. If it gets to be over 5 centimeters, then a recommendation for treatment is made. The only treatment we have for dermoids is removal, so that's going to be surgery. Surgery is usually going to be done with a camera. We call that laparoscopy. We put a camera in the body and other additional instruments to open the ovarian tissue capsule that's formed outside of that growing mass of dermoid cyst, and then we remove or scoop out the cyst and repair the ovary. So let's see, dermoids are benign. They're mostly in young reproductive age women. They're usually filled with gunk, hair, teeth, all of the tissue, skin, sweat, glands, all of the skin type of layer, what we call the ectoderm. There's never an emergency to intervene and remove the dermoid unless it's larger than 5 centimeters. Dermoids can get quite large. I've removed dermoids from patients I've had that are 10 to 12 centimeters. I think statistically they can get up to around 17 centimeters. So 10 or 12 centimeters is the size of a cantaloupe, grapefruit to a cantaloupe. 17 is going to be the size of about a 4.5-month pregnancy. And let's see, there is about a 10 to 15% recurrence rate, either in that same ovary or in the other ovary, because it's the same person, so their ovaries are going to be the same. And let's see, recovery from laparoscopic surgery is 1 day, so it's very easy. If someone has a lot of potential scar tissue, they've had surgeries before, they have a lot of scar tissue, or they've had a lot of inflammation, the dermoid cyst is matted and scarred in the body, then that might require an open surgery, which we call a laparotomy, where it would be a large cut. We call those bikini cuts, so side to side. So I hope that's been helpful information on ovarian cyst, the dermoid ovarian cyst, or mature cystic teratoma, the monster. This is Dr. McDaniel at GYN Corner. Thank you for joining me. Please hit the follow and the subscribe buttons if you enjoy the content. You want to get a heads up on what's being presented and when the presentations are occurring. Please check out the podcast, Apple iTunes, Podcast Addict, Spotify, Google, Anchor, and please place a review. Let others know that you enjoy watching GYN Corner, what you like about it. Please place comments here on Facebook and on YouTube, GYN Corner, to let me know if you have any questions, anything I can answer, and any topics that you'd like to have presented, you'd like to have information on. Have a great rest of your Thursday, and have a wonderful, here in New York it's not so wonderful, but hopefully if you're in other parts of the country, it's kind of cloudy today, have a wonderful sunshiny day. Thanks again. Till the next presentation. Bye.